I've been really focused on the importance of access to treatment, that we have to have treatment that's accessible, that's affordable, and available. And we have problems on all of those scores. Like other jurisdictions, New York City faced a growing number of overdose deaths, the majority of them related to opioids. The mayor called together a task force and made new funding available. And that helped us with both our data. It's really important to have data, timely data. Helped us with new innovations. Emergency departments, for example, where people survive an overdose, is an opportunity to get that person to a safer place, to initiate treatment. Also, the New York City Health Department began providing supports to integrating buprenorphine prescribing into clinical settings. So many providers who are trained and waivered to prescribe buprenorphine don't ever actually write a prescription. So we need more people who are trained. But we need more of the people who are trained to begin prescribing. So New York City and many jurisdictions are really putting on their thinking caps and trying to think of new ideas, and the Healing NYC initiative allowed us to have some resources to do that.
The role of epidemiology in curtailing the epidemic, I think, is critical. We use data to understand and classify the extent of the problem, to identify which communities and which people are affected and what services are being provided so that we make sure we get what's needed to the people who need it. We've got some communities that are being oversaturated with services and supports. Then we have some communities that aren't getting anything, even though they have very high need.
New research coming from our colleagues at the University of Michigan just in the past month have demonstrated important racial and ethnic disparities. For example, African Americans are much less likely to receive medication-assisted treatment for opioid dependence, even though they have a similar risk to white Americans for developing opioid dependence. We've also seen differences, for example, between rural communities or inner-city communities that may not have providers who are certified to treat opioid dependence and prescribe some of the medications that are effective for addressing opioid dependence.
I think we need the ongoing surveillance system in place. We need to apply what we know works, and we need to do the ongoing monitoring and evaluation to make sure that it's working, de-implement the things that are not, and be innovative to put in new strategies when needed. When you look in places like Baltimore, where there's been a heroin problem for more than 30, 40 years, we put the systems and structures in place, and in the face of a rising national crisis, Baltimore's actually remained somewhat stable. When you implement evidence-based strategies, you actually can change the outcome. Prevention works, treatment works. It's time to put the evidence out in front of values and judgments about this community. Addiction is a disease, just like any other disease, and it's preventable and it's treatable.
We have to have a serious conversation about stigma. We have to think about what it is that makes people who use drugs so ashamed, people who love them so ashamed about talking about it. The healthcare providers whose job it is to look after them continue to feel uneasy about taking care of somebody with a substance use disorder. We need people to understand that this is a disorder that people need help with, about which none of us should be ashamed. Any one of us can become addicted to opioids.